Rapid strides in research and technology bring us to special situations in which we have to anesthetize patients. The last session today deals with giving regional anesthetics in such difficult situations. May I call upon Dr. Bala Venkat, who is the founder and current president of AORA, as expert. The first speaker is Dr. Murali Chakravarthy. He will be speaking on regionals for cardiac patients for abdominal surgeries.
The opportunity is actually good that Bala is not there, because there will be nobody monitoring my time. And also, actually Sandeep gave 2 minutes, that also I'll add to my own. So it will be 17 minutes. Okay. Actually, my topic was anesthesia for patients with cardiac disease undergoing abdominal surgeries. Since it was a regional anesthesia conference, I thought that I'll dwell more on that, but of course not only on that. I'm actually foreseeing a situation where all of you go home and then you discuss what kind of anesthesia are you going to give. So I will tell my resident that let's give GA. Why GA, sir? You are an old timer. We had a conference, we discussed only regional anesthesia. You should not get general anesthesia. No, please don't go away with that feeling. You still have to give general anesthesia. You know, regional anesthesia is like a girlfriend, general anesthesia is your wife. So, what are the issues with cardiac patients? We have cardiac issues, medication issues, surgical issues, general anesthesia and regional anesthesia. All of them do cause issues. And the cardiac issues, we all know that it could be ischemic heart problems, or it could be valvular disease, or nowadays we get a lot of we call gooch, grown-up congenital heart patients. And these patients, we have pulmonary hypertension, and also they have systemic hypertension. And I am not going to give you gyan about what we have to do in patients with ischemic heart disease. You all know how we have to maintain the rate pressure product, how we take care of the myocardial oxygen balance, and how you will not cause hypotension, hypertension, hypoxia, hypercarbia, and acidosis, hypothermia. These are the general rules. It will hold good even here. In valvular lesions, there are some general guidelines. And I am not telling you whether you must give general anesthesia in a valve or you must not give general anesthesia. There are some guidelines. Generally, in a very tight aortic stenotic patient, we don't give a regional anesthesia because those patients may not recover the hypotension and they develop severe coronary hypoperfusion and they may have ventricular fibrillation, and you will never be able to recover from that. And in children with adults, adolescents with congenital heart, we are operating so many congenital heart patients now in India. A lot of them come after ductus ligation, Fallot's correction. Even we have done some surgery, general surgeries on patients who had arterial switch operations. Things like that are not uncommon. It's not like it used to be earlier on. We would see only patients with ductus ligation at the most, because all other patients did not survive, babies. No, it used to be very bad. But in Indian pediatric cardiac surgical scene is very good. We have very robust programs going on. Even in this own Pune city, we have a fantastic cardiac surgical program going on. So we get a lot of those babies too. Pulmonary hypertension, you must understand that it is going to give you trouble whether you give general anesthesia or regional anesthesia. We have done a few studies and we have published also that pulmonary hypertension is favorably benefited by regional anesthesia. So, in cardiac patients, we are given thoracic epidural anesthesia, and the sympathectomy that it causes also reduces the pulmonary hypertension. And let me tell you, we all think that we know a lot about epidural, sympathetic, parasympathetic. We don't know actually. We don't know how pulmonary hypertension can reduce. Theoretically speaking, when you have a sympathetic block, you must get bronchospasm, you must get pulmonary hypertension. None of that happens. None of my colleagues who practice thoracic epidural will vouch for it. They will all vouch for with what I am saying. It doesn't happen. So my understanding is that we need to study these aspects a little more. And systemic hypertension in patients, especially with aortic stenosis, aortic regurgitation, are issues that we have to be concerned about. And then we have issues of antiplatelet medication. So that we'll have to ask Bala, because Bala is going to tell you tomorrow, and also we are going to have a pro-con discussion whether we should have antiplatelet. I'm just kidding, but as of now, the guidelines and the recommendations say that if you have antiplatelet medications going on for the last 1 week, then you don't put a regional block, especially the Neuraxial blocks. And we have now clear-cut guidelines from the American Heart Association and the American College of Cardiology. If you have ACE inhibitors, you should stop it. If you have beta blockers, you must continue it. Antiarrhythmics, the current recommendations, you must continue. Although they are pro-arrhythmics, it's better to have a different arrhythmia than old dangerous arrhythmia like a VTAC or VF. And diuretics should be stopped, and also simultaneously you must look at the potassium, other values. Statins must be stopped. Earlier on, anesthesiologist said that I don't have anything to do with statins, not anymore. We need to stop them. Calcium channel blockers can be continued, they don't really worry. The surgical issues, if you really plan to do a regional block, is one is relaxation. So we need to have a perfect block working, otherwise you should not carry on with the surgery. Like Bala said in the morning, I was really shocked at a shoulder manipulation patient dying of laryngospasm. I think it's a shame. We should never get into that kind of ego trip. And I always believe, my professor used to tell me, if a block doesn't work, blame yourself. And we must quickly convert into general anesthesia, because general anesthesia is not poison. And like I said, the regional anesthesia is not panacea. So let us keep our strong head on calm head on strong shoulders, think properly for the patient. And then surgery on great vessels is a different cup of tea. You must take them very, very carefully, because that is one of the risk factors. Even Goldman risk factor in 1970s includes the thoracic and the vascular surgeries as one of the risks. So we have to be careful. In intestinal surgery, we do have problems, but we have choices. A lot of people do abdominal surgeries, even surgeries like lap chole, etc. in cardiac patients under spinal anesthesia. So I'm sure that's a topic which has to be discussed, and we have to understand, and I urge Aura to give us all the guidelines as to how it is done. And urology and oncology surgeries are, in elderly patients, they have multiple problems, and in those patients, they will be on anticoagulants and they have renal dysfunction, or the surgery can cause blood loss. So we have to be very careful along with the surgery. And this was one of the thing I found. I need more relaxation, and anesthesiologist asked, how about a trip to Bangkok? I think we better give relaxation. And the surgical issues, I told you, aortic surgeries are high risk, and we must be always in readiness to combat hemodynamics. If you are not in a position to combat hemodynamics, I mean to say, put an arterial line, put a central line, if necessary, have a cardiac output monitoring, etc. Please do not take that case. You will be called negligent. You cannot say that we don't have that, so we had to do. If you don't have, get some help. Please, that is the only way we progress. 50 years ago when you said there is no ultrasound, nobody would have bothered. If you say now, I caused a carotid artery puncture in a patient with a carotid block, because I don't have ultrasound, it might become negligence. And prepare well the patients, the heart failure, diabetes, arrhythmias, electrolytes, thyroid problems, etc. The anesthetic issues, we must have smooth induction, monitoring a recovery, whichever. Even if you are giving a patient a regional block or accessing the arteries or veins, etc., they should be done by experts in single shot. You can't have multiple holes on the veins and multiple holes on the artery. He will after 6 months come back with an AV fistula, which will become a surgery on the vascular structure. So it will be a dangerous surgery. So be very careful, be astute, and use all the help that you can. Use ultrasound to put all the monitoring lines. And if you give a block, make sure it's a good block. And if it doesn't work, you don't have to worry. If you can reschedule or reblock, fine. Otherwise, give general anesthesia. And then monitor depending on the severity of the cardiac issue. In all patients, we must have SaO2, NIBP, ETCO2, ECG, etc. And in invasive BP, SWAN, etc. if it is little severe patient. And transesophageal echocardiography is one more thing which you will be learning, which is an add-on to the ultrasound image. And then that depends, if you have the experience and the equipment, both are available, then I think you should do it. In general anesthesia, I told you, you have to follow the rules that we normally are advising. We talk in conferences. Hypotension will occur at induction. Be careful. Don't bolus drugs. Be gentle. Administer drugs as small aliquots till a patient sleeps. You don't have to calculate the dose and bolus that, whether it is propofol or rocuronium. And intubation hypertension should be avoided. Myocardial depression should be avoided. There is one good thing which is recently emerging about general anesthesia is that inhalation anesthetic agents protect the heart. How much of that is therapeutic is not proved, but the American College of Cardiology and Heart Association give this as a grade 3, level 3 indication to use inhalation anesthetic agent. And then never administer one technique of anesthesia. If you give a regional block, give some kind of a sedation. If you give a peripheral neural block, you can give a light general anesthesia. So make sure that the patient is overall comfortable. And neuraxial block could be with or without general anesthesia. If you have a very critical patient who cannot take general anesthesia, I agree. Otherwise, give some kind of a sedation, sleep so the patient is comfortable. Take care of the antiplatelets, hypotension, preloading of the patient during a block, and then the role of echocardiography. I am a very ardent fan of echocardiography. We do ultrasound in all forms, whether it's nerve block or spine or neck or airway or transthoracic echocardiography or transesophageal echocardiography. We do all of them. So we have 2 echocardiography machines in our own setup and 1 portable in our ICU. So that is going to be the future, I feel. The way we are progressing with ultrasound, the using of ultrasound for assessment of heart is not difficult. Once you know the knobs, it is not difficult. So please start using, if you have an echo machine, put the 5 megahertz probe on the chest and start looking at the heart. It's good. And of course, I'm not a very big fan of multiple injection blocks like paravertebral block. If you want to operate on the chest, you have to put multiple injections. I'm always reminded of this Bhishmacharya lying on the throne, patient having 10, 15, and this is the anesthesiologist saying, don't worry, everything is okay. I don't like that. And nerve blocks and infiltrations are definitely in. Whether it's tap block or intercostal block could be good for abdominal surgeries. Although tap block can be used limited extent for lower abdominal surgeries, we cannot use it for all the surgeries. But I am sure with our imaging getting better, we will be able to block multiple intercostal nerves, etc. Another thing, when you are doing a block in and around the chest, you also should train with your thoracic surgeon to insert the intercostal drainage tube. It can be life-saving, and even if you could put a cannula and reduce the tension pneumothorax with patients, and it will be the standard of care. We heard Dr. Vincent talking about it. I have no doubt ultrasound will be the standard of care, and if you don't use, it will be difficult. Never block alone, you must have some other sedation too. And infiltration and with local anesthetic is not always safe. You see, in Bangalore we had a huge case where a boy undergoing gynecomastia was uneventfully induced by an anesthesiologist. Surgeon administered bilateral for both the breasts, local anesthetic, and I think it went into the vein, and the boy had a cardiac arrest, died after he was brain dead for a few days. So please remember that it's not going to be rare, so we have to be extremely careful about all these things. Of course, inhalation anesthetic and myocardial protection is a new topic, and it is recommended now that if your patient has got ischemic heart disease, definitely you must give inhalation anesthetic agent. So whether it is for the patient's amnesia and reflex suppression or not, at least for the heart you can provide, and more data is emerging now. And we did a study, we found that it was not useful in beating heart surgery patients. But it is very, very new topic, and I'm sure a lot of exciting things are going to come. It produces what is called as a ischemic preconditioning, or IPC like feature, and it's supposed to prevent the cell apoptosis and prevent the myocardial dysfunction. So inhalation anesthesia in a cardiac patient, especially ischemic heart, just keep it in the background and it might help you. In our own hospital, the trend has been, this was the trend in 2007 when we used to administer a lot of epidural anesthesia. Now you can see we administer GA with femoral and sciatic nerve blocks. You can see number of cases and the number of general anesthesia is decreasing. Spinal, the epidural is almost gone, with even increasing number. There's no epidural. We are more into blocks and light general anesthesia. It works well. Our surgeons don't stop anticoagulant medication. I feel it's a good idea, but I still don't have the guts to put an epidural in a patient like that. So we do the femoral and sciatic nerve blocks for our knees and give a light general anesthesia for hip. So you can see that in our case the nerve blocks have been increasing, and that is in future would be the case in all the hospitals. And you can see the huge jump in the femoral-sciatic block because we are doing all patients who are on anticoagulants as well. We don't stop it at all. Patient with stent, no problem. So This is not a good way to administer a block. If you administer a block, it should act and surgeon should operate. And these, of course, the extensive monitoring that we do. You must have all kinds of monitoring. These are some of the cardiac patients undergoing surgery. And this patient, I will end with this. This patient had a hernia like this. And she was very sick, aortic stenotic patient. She wanted surgery. We said no surgery. But she said, no, I have to get operated. Why? We asked, why at this stage? She said, you know, my grandchildren come and turn my saree and do that pom-pom and go away. I don't think the grandchildren were unhappy.